Please join me in welcoming Dr. Gonzalez.
Hey, good afternoon, everyone. Thank you for that lovely introduction. I was introduced, my name is Victor Gonzalez, and I'm going to be talking about extracorporeal membrane oxygenation, or ECMO, as a rescue in the ICU. And I have no disclosures. So here are my learning objectives. We're going to identify the utility of ECMO as a rescue technique in the ICU, and then we're going to examine some of the outcomes of patients undergoing mechanical circulatory support, predominantly ECMO. And then I took a twist at the end of the talk to see if I can also show you guys the use of ECMO as a rescue, and it's being implemented outside of the ICU and predominantly in the perioperative area, something that we'll be seeing as anesthesiologists in the future. So just a brief timeline. The first membrane oxygenator, so basically this is like a device that bubbles oxygen through a membrane and then we can transfer oxygen and remove CO2, was developed in 1955. And actually the first membrane oxygenators were used beyond animal studies were actually in children and neonates. So if you look at some of these very early membrane oxygenators, and then you can imagine someone using that on your child during surgery, you'd be like asking a lot of questions. So I'm not really sure how they developed some of these, but if you look at some diagrams, they're very interesting. It wasn't until 1972 that the first successful patient had ECMO done. It was an ICU patient that developed, back then they didn't know it yet, but it was ARDS. After severe pneumonia, and the patient survived being cannulated off of ECMO. Unfortunately, didn't have a good long-term survival, but the placement and removal of ECMO was actually done successfully. It wasn't until 1989 that ELSO, or the Extracorporeal Life Support Organization, was founded due to these new membrane oxygenators. Cardiac bypass was already being done for surgery, and so they made this organization in order to help see if they can provide guidelines, provide better research, organize. This is also an international group, and then see if they can organize their thoughts and then provide recommendations for all this new technology at the time. These two next moments here in time are very well done. The first randomized controlled trials for ECMO patients. These were the Caesar trial that was published in Lancet in 2009, and then in 2018 the Aoca trial, which was published in the New England Journal of Medicine, and then we'll touch up on those as well. So what is ECMO? It's as simple as ELSO, the ELSO, this defines it as the form of mechanical circulatory support for patients with life-threatening illness or injury that affects either the lungs or the hearts or even both. Okay, so the most basic function of ECMO, as I'm going to try to describe it, is you remove desaturated blood from a vein, you give it some oxygen somehow in a magic machine, and it removes CO2, the same functions as our lungs, and then you give that oxygenated blood back in through either a vein or an artery. It'll make more sense here, but before I go into the diagram, just the basic components of ECMO is you need some sort of cannula, something that goes inside of a patient's vein. It will remove deoxygenated blood. You need a pump, a blender to mix oxygen and air in order to create a significant, whichever FiO2 ratio you like to create. You oxygenate the blood. You can have a heat exchange component, and then you control it in order to it goes back to the patient. So if we look here, I'll show you with the mouse. We have deoxygenated blood being removed from a patient. Some sort of pump goes into this magic machine here that has a membrane oxygenator. You get O2 in, CO2 out, and then all that oxygenated blood goes back into the patient. These are the two very basic configurations for ECMO. So here we have something we call venous-venous ECMO, or VV ECMO, which if you look here, this cannula is all the way in the IVC of the patient. It will draw blood out. This pump creates negative pressure, draws the blood out. It goes into this oxygenator, and then the oxygenated blood goes right back in to the SVC. Then the heart will take care of the rest and pump it the rest of the body, and then the body has oxygenated blood. If you have heart dysfunction, it's a similar setup where you have here in the IVC, this cannula will draw blood out into the pump, gets oxygenated again, and then this time it'll go retrograde into an artery in order to perfuse the rest of the body. So you get oxygenated blood going into the kidneys, the gut, the brain, etc. It's kind of like similar to when we do a cardiac case when you're going on bypass. All right. So there's two different, or there's actually various. ECMO comes in two different flavors, but there's also like some sort of accessory modes. So venous-venous ECMO, or VV ECMO, is used in patients with severe respiratory failure that's refractory to conventional therapy, and I'll talk about that in a little bit. Then there's the other version of ECMO, VA ECMO, or venous arterial ECMO, and this is used to support patients with severe cardiac dysfunction. I'll touch up a little bit about VA ECMO in a little bit, but there's other devices that we have here that's not ECMO that may be better suited depending on the patient population. And then there's a couple of different variations of both where we have venous arterial or venous ECMO. So there's different configurations. There's VVA, VAV ECMO, and these are reserved for specific patients where they're developing circulatory and respiratory dysfunction at the same time. So it's a salvage in order for severe combined respiratory and cardiac failure. All right. So now we know about more or less what ECMO is, different configurations. So who gets on it? Who goes on ECMO? Who gets this therapy that's this fancy new therapy? Well, it's not really new, but new technology is coming out that making it more accessible to other places in order to people who didn't have ECMO before now do. So the Extracorporeal Life Support Organization, or ELSO, has specific indications for ECMO. So its primary indication for ECMO is severe heart or lung failure with high mortality risk despite optimal conventional therapy. Can be considered with mortality risk of 50% and is almost always indicated in mortality risk of about 80% in patients. Most common indications are severe hypoxemic respiratory failure, hypercapnic respiratory failure, or ventilatory support as a bridge to lung transplantation or graft dysfunction after a lung transplantation. All right. So now I'm going to talk very brief. I'm not going to try to basically, this is not a journal club, but basically I'm going to show you a few trials, two on VV ECMO and one on VA ECMO. And the first one was a very well done trial done in 2009. A bunch of smart people published this in Lancet in 2009, and it was basically called the Caesar trial. So it's the efficacy of saying, okay, severe ARDS patients, do they go on ECMO? How do they do versus conventional therapy? Basically, prolonged mechanical ventilator support, neuromuscular blockade, proning. They looked at all these things. So it was a prospective multi-center, randomized controlled trial done in the UK. Conventional therapy versus ECMO patients in severe RDS. And this paper is very, very well done, very, very long. And bottom line, they concluded, ECMO is cost-effective and does increase survival without severe disability at 6 months compared to conventional therapy. So basically, it didn't say ECMO is better or ECMO is worse versus conventional therapy, but they said it was almost like a non-inferiority trial. They say ECMO works for this subset of patients. And they had a 63 survival rate in the ECMO group versus 47% in the conventional group, but it was not statistically significant. So of course, trials kept going, and then in 2008, another group of very smart people published this in the New England Journal of Medicine, the Aoca trial. Again, a prospective multi-center randomized controlled trial. This was done in Europe, and they basically took 250 patients approximately, and they had a control group, the same. Patients were prone, mechanically ventilated, they had pressors and all these things for very sick patients depending on how they got the ARDS. And then they had an intervention group where they said, if the patient was trending the wrong way, early on, we'll just initiate VV ECMO. We'll take blood from desaturated blood from a vein, oxygenate it, put it back in the patient, see how these patients do in the long term. Then they also had a crossover group. So if the conventional group patients, the patients were mechanically ventilated and prone and were not doing as well, they would be rescued with VV ECMO. All right. So this crossover group, they set a few limits, basically saying if they were prolonged, very sick patients, very prolonged, not doing well, saturation is less than 80%, they would go on VV ECMO. So the outcome was no statistical significant difference in mortality at 60 days. And the ECMO group had a survival rate of 35% versus conventional, 46%. So it's kind of a mixed data. So saying, why do we keep doing this ECMO thing if it in the long term doesn't work? But keep in mind that the crossover group, with these very sick patients on conventional therapy, were rescued and then put into the ECMO group. So that's always something to keep in mind. So kind of saying, the really sick patients, we kind of try to rescue last second with ECMO, didn't do so well. All right. Now this one's a little different. This was actually published in Circulation in February of this year, in 2023. It was the first large-scale randomized controlled trial published in Circulation by another group of smart people about VA ECMO, saying patients have severe cardiac failure, let's put them on ECMO. VA ECMO, so basically taking blood from a vein and putting into an artery in order to, so the heart can relax, doesn't have to do the job of perfusing the rest of the body. So there was a prospective multi-center randomized controlled trial. They got a bunch of patients, and again, I'm not going to bore you with all the details, but basically saying, again, what a surprise. No statistical significance in difference in mortality in cardiac arrest or implementation of another mechanical circulatory at rest at 30 days. So the ECMO group had a survival rate of 64% approximately, and the control group 71. So it wasn't better. But keep in mind that for helping the heart, we have a couple other well-studied devices. Balloon pumps, we have Impellas, we have tandem heart, we have cardiopulmonary bypass to go on surgery. So this was not as well done as the ARDS trial, but they're trying to say that ECMO, and also there's a group of cardiologists that believe that instead of going on VA ECMO, where the heart is still kind of working and you don't really kind of help decompress the left ventricle, you're not really helping it out. And ECMO, all it does is just perfuse the rest of the body. It doesn't really do anything for the heart. And then when the heart starts working, it has to kind of work against the ECMO. So they weren't really sure how well the VA ECMO works for patients with cardiac failure. But keep in mind, this VA ECMO is not only for cardiac failure, it's also for patients, for example, with severe lung disease that have RV failure, and then the heart's not working too well. So now you say, okay, let's go on ECMO. So what happens next? Here we have an ICU patient, a few drips on, mechanically ventilated, not doing so great. So how do we make this patient look like this patient? So again, ECMO is a big deal. It's a lot of steps that I'm about to show you to go on ECMO. It's not just saying, oh, hey, you know what, no big deal. We'll just put this ECMO, after we round, we'll put a patient on ECMO, they'll be better. It's a lot going on. So initiating ECMO. So here are the steps. You have to activate the ECMO team. So first question you have to ask, is this facility ECMO capable? Okay, you have to call in the ECMO surgeon, call in a proceduralist if they don't have a surgeon on standby, anesthesia, call in perfusion. Is the ICU ready to handle an ECMO patient? Initiate transfer to a regional ECMO center if you don't have these things available. What's the urgency? Is this a crash on ECMO at the patient bedside in the ICU? Or can we have time to roll this patient to the operating room, have a more controlled environment, have better things set up in order to put this patient on ECMO? They need image guidance, all right? So we've done ECMO. You can have it with TEE, emergency at bedside in the ICU, or if you have a procedural room or a hybrid OR, you have TEE and fluoroscopy. Is the X-ray technician, are they still the only one available, is still doing that 14-hour spine in the other OR? Can we get them in the OR to put this patient on ECMO? These are a lot of things to consider. Hospital capabilities, like I said, is the ICU ready to take on an ECMO patient? This is absolutely critical for the ICU attending, the ICU team, the nurses. This is one-to-one patient management. And if not, do we proceed with transfer? And then here's a cool picture. So now we have, this is I think in the University of Minnesota. Now they've made ECMO ambulances where they actually have the capabilities to put patients on ECMO in the ambulance and then roll immediately to the nearest regional center where they can appropriately ready to take care of ECMO patients. So steps to initiating the ECMO. What type of ECMO do we need? Is it VV? Does the patient have ARDS? Is it VA? Patient has cardiac failure, maybe some sort of combination. Do we have to implore one of these hybrid types of ECMOs? Do we pull from a vein, give to an artery and a vein, pull from two veins, and then give to one artery or one vein? So it's a lot of different combinations, and that nuance is not really going to be well described here in this talk. This is more of an introductory to kind of show you what ECMO is going, where it's been and where it's going. Cannulation site. Does this patient have a dialysis line in the right femoral vein that we want to use for ECMO? Does this patient have a right IJ where we also want to put an ECMO line? Do these lines have to be moved? Do they have an arterial line in a femoral artery that we have to remove now for another one? What do we do? Where do we get the patients clamped down from being on pressors for a couple of days and we can't get a radial arterial line for blood pressure monitoring? These are a lot of things to consider. It's not easy in saying, hey, look, no big deal, put a patient on ECMO, go home. So starting ECMO, then there's a whole science behind this. What flow rates do we put? We're providing cardiac output in VA ECMO. Do we start at 2 liters a minute? Do we start at 4 liters a minute? Take the patient's weight into account. Oxygenation, do we just put everyone 100% FiO2 or we never wean this patient from ECMO? How much CO2 do we remove? How fast the CO2 we remove? These are a lot of things that we have to keep in mind in order to put a patient on ECMO. These are all things that have to be titrated accordingly, and then also temperature regulation. You're removing from a warm body, going out into an external circuit that's at room temperature and then putting it back in. You have to keep a lot of things in mind. Considerations when patients are on ECMO. Some patients have to be anticoagulated. A lot of the newer cannulas are kind of coated with thrombotic agents, so you don't have to anticoagulate as much, but that's a big issue in the past. Labs, of course, every ICU patient has to have Q1 hour labs and all these other things. Weaning hemodynamic support. You put a patient on ECMO, you're not going to need 40 mics a minute of norepinephrine or levofed anymore, so you got to start weaning all these things off. Ventilation strategies. Do we put this patient on low tidal volume lung protective strategies? Do we continue the aggressive? Do you don't have to prone anymore? And also VA ECMO, there's this discussion like I mentioned before, do we offload the LV? Is the LV working extra hard now that it's competing with flow? And there's also something called north-south syndrome, and that's beyond the scope of this talk, but it's a complication from VA ECMO where the heart starts working, and now it's pumping deoxygenated blood into the head, and then you have to kind of like combat that and put another extra cannula in. So now, this is where I'm going to switch here, my talk. Is ECMO only for ICU patients? So over the last 10 to 15 years, we've seen a more expanded role of ECMO kind of creeping into the perioperative space. In anticipated difficulty airway cases, now we have ECMO standby. For difficult tracheal tumors, tracheal stenosis, head and neck tumors, we can have this patient with an ECMO team in the room. If you cannot establish a secure airway, they go on ECMO and we buy time for this patient. Transient ECMO for assisted thoracic surgery cases. Before it was a double lumen tube. If you're not tolerating one lung ventilation, you go up on the FiO2, you go up on the PEEP, you clamp the PA, but now we have this option of ECMO. Go on ECMO, finish the thoracic surgery, wean the patient off ECMO, and they get into the ICU. Lung transplantation has been a completely different ballgame since ECMO has been. You don't have to now go on cardiopulmonary bypass, anticoagulate this patient, and transplant 2 lungs and then deal with bleeding at the end of the case. There's also a non-emergent ECMO cannulation prior to thoracic surgery, and I'll go into that in a little bit in this paper I'm going to demonstrate. And also, the newest thing that's coming in is pre-hospital ECMO initiation, and it's extracorporeal cardiopulmonary resuscitation, or eCPR. Refractory CPR patients are now being cannulated in parts of this country and in Europe, cannulated on ECMO if they don't have a ROSC within 15 minutes. So there are some anesthetic considerations. So I think 2 or 3 years ago, anesthesiology published a really good review article on saying, there's a patient on ECMO in the ICU, it's going to the OR, you're the only person there, what are you going to do? All right. So again, this is something that's still pretty new and then not everyone's comfortable taking care of, but a few things that I listed here are very important to consider when a patient's on ECMO going for surgery. If you're going to either put them on ECMO or they're already on ECMO, you have to consider volume status. If you have a very sick patient who's been in the ICU, hemoglobin's like 7.8, and they're about to go on ECMO, all that reservoir is going to be pulled about 500 to 800 milliliters of blood, and that patient's going to get very profoundly hypovolemic. Are they anticoagulated? Is this ECMO patient someone who needs a bowel resection all of a sudden in the middle of the night, and they're on a heparin drip or they're on some other form of anticoagulation? Bleeding. Are you going to now, you put this patient on ECMO, and now you're going to give plasma, platelets, cryo, activated clotting factors, you're going to clot the ECMO circuit. So these are all things that before, when a regular patient is having surgery, that, okay, patient needs blood, give blood. Patient needs platelets, give blood. You need to keep things in mind because the worst thing you can do is then patient dependent on ECMO, and then you form a clot in the system. All right, anesthetic, choice of anesthesia. These patients are not going to be moving any tidal volumes, so inhaled anesthetics are not going to work. So TIVA is probably the best choice. And then transporting this patient. Some ICUs are 2 buildings away in a really brand new building ICU that the hospital loves, but it's now 2 floors away, and take 2 elevators on a busy Friday afternoon, and you have to transport this patient all the way to the operating room. These are things you need to be very careful of. So now the future of ECMO. So eCPR, does it work? So for the last, I'd say the mid-2000s, they've been doing these, first it started with in-hospital cardiac arrest, placing those patients on ECMO sooner rather than later in order to achieve ROSC faster. And then the studies started going out of hospital, then post-op cardiac arrest, and then all these studies have pretty much been inconclusive, saying, you know what, crashing onto ECMO bedside on the 4th floor or the parking lot, it's not really that good for these patients. It's a lot of things going on. It's an invasive procedure. It's a surgery pretty much on the fly in an emergency, and these patients don't really do much better than just going through ACLS protocol. That's why it's so well documented, ACLS protocol, and it's updated constantly. This year, in New England Journal of Medicine, they published a group paper, the eCPR for refractory out-of-hospital cardiac arrest. And I'm just going to give you more or less the tidbits. So average time for EMS to arrive to a patient that had a witnessed cardiac arrest was 8 minutes. Arrest to ECMO cannulation was less than an hour. And arrest to hospital arrival was about 36 minutes. So most of these patients got on ECMO actually when they got into the trauma bay. And survival with favorable neurological outcome was similar in both groups. So again, this study showed, patients who just kind of rushed to the hospital into the emergency room or placed on ECMO either before or after getting to the emergency room, they kind of have more or less similar outcomes. But then a follow-up paper was done, I think this was done in China, and then it showed timing of ECMO, how important it is. Instead of waiting for sick patients in order to be crashing and then going onto ECMO, this Kaplan-Meier curve shows non-emergent earlier intervention, putting patients on VV, this is for VV ECMO for ARDS and lung patients, had almost double the survivability as patients had crashed onto emergency ECMO. And these patients who later required surgery, 0 had intraoperative cardiac arrest, and about 40% of the crashed onto ECMO patients later had, 40% of those patients had cardiac arrest. So this is, again, showing that timing and decision to go on ECMO is extremely important. Here's a cool picture. This is a pre-hospital ECMO unit in France. This is a patient who was in the subway and then had a witnessed cardiac arrest, and they put him on ECMO within 20 minutes and then rushed to the hospital, and this patient actually survived. Here's another patient in my training institution that we actually did I think he was from Connecticut. They said there was nothing they can do. He had bilateral intrathoracic tumors, and they said there was nothing we could do. This is pretty much palliative. So patient was seen here at the University of Miami, not here, but at the University of Miami, they said, here's the plan. We're going to go on ECMO. We're going to take your 2 lungs out. We're going to debulk the tumors, and we're going to put them back into your lungs. And this is him a week later. He's extubated, still on ECMO. We can see the cannulas here in both of his necks, 1, 2. And he's on high-flow nasal can. This patient walked out of the hospital. This was impossible to do unless this patient had ECMO for 3 weeks before and after surgery in order to optimize him before surgery, and then we wean them off. So you can have patients walking in the ICU, extubated, receiving oxygenated blood. All right, and I think these are my references.
Thank you, Dr. Gonzalez, for this enlightening talk. And as I mentioned before, Dr. Gonzalez does have a flight to catch, so if you guys have any questions from the audience, this is where we're going to entertain it.
Thank you. Again, Dr. Gonzalez, that's incredible to see the technology that's employed and the miraculous capabilities it can provide to prolong and save lives. My question, in seeing this, what did that cost in France to bring the team to that subway and implement the entity that would ECMO and then brought him or her out to the hospital, or to your gentleman from Connecticut with his debulking?
Yeah, so ECMO technology is very expensive, and there's very few companies that actually supply these devices. And most of the companies are European. I don't know, I know that the European Union has a society that funds this through that company, Macit, which is the most, I think it's a Swedish company, and they kind of subsidize medicine there. I don't know the exact cost, so I'd have to get back to you with that, but it is very expensive. I think the average placing ECMO at the university or the Miami Transplant Institute was about $40,000 to go on ECMO and then watch him in an ECMO unit in the ICU after that for about a week.
Probably a lot of croissants. I do have one question for you, sir. So given the fact that we do have mostly generalists here in the audience, let's maybe talk about a bit about a clinical scenario. Let's say you're a generalist that somehow happened to have an ECMO patient in the unit, and it's a Friday evening, and the patient is VA ECMO with no distal perfusion cannula, and the leg is cold. And then you're called to the bedside and told that, hey, we need to take this patient to the OR immediately for fasciotomies and for a distal perfusion cannula. Can you give us just like a little tips that a generalist can have that they can look for? If, for instance, like where the arc line is, what is sweep, what's oxygenation,
right?
Things like that.
So this is important because usually in the ICU, the patient's just there on ECMO. There's an ECMO perfusionist, and you kind of, like I said, sweep. So what sweep does is basically remove CO2. So basically that's our way of increasing minute ventilation. And then FiO2. So the most important things to look at is look at the volume status of the patient. I would say that's the most important thing because a lot of times patients are on ECMO and then you start anesthetics on them, you vasodilate these patients and they can become profoundly hypotensive. So that's one thing. So basically have blood ready. Make sure the blood is ready to go. Have help early on in the room. This is, I'm not kidding when it says it takes a village to transport these patients. These patients are mechanically ventilated. They're on ECMO. They're on drips. They're receiving blood transfusions. They might have inhaled nitric oxide or inhaled ibuprostanol for pulmonary vasodilators. So for sure have help available. Have an extra set of hands in the operating room. This is definitely a case where you keep this patient on the ventilator from the ICU ventilator. It's not a time to play around with the anesthesia machine and try to switch them and try to remove the circuit or the airway. And then absolutely have perfusion on board. And then communication with perfusionists is important. You need to know the flow at all times. Get ABGs every 15 to 30 minutes in order to make sure that the sweep and the FiO2 and your perfusion, look at your pulse oximeter. These patients are not healthy. It's not going to be saturating 100%. They're going to be in the 80s. Keeping that patient safe. Like you said, distal limb ischemia is a very common complication of ECMO because you have these large cannulas in the femoral veins and arteries. And so, yeah, sometimes what they do is they take a branch of this ECMO circuit of oxygenated blood and put it right back into the leg. But these are plans that you have to discuss the plan with the surgeon, have an extra set of hands to help, transport this patient very carefully, and again, making sure the patient is mechanically ventilated at all times.
Would you mind commenting about the location of the arterial line for VA ECMO and the implication it has for the cerebral perfusion?
Yeah, so the most common place for arterial line placement is actually the right radial A line. So this is the one that you will be taking samples of in order to test to see, because what the perfusionists will do is that they'll take the blood sample from the oxygenated blood and say, okay, obviously it's oxygenated, looks great, but you have to take a sample from the right radial A line of the patient in order to see this is the oxygen content that the brain is getting. Or even the left radial A line you can also use, but basically sometimes if the heart is pumping deoxygenated blood, you will get something called north-south syndrome, and where the patient is getting distal perfusion, retrograde perfusion somewhere else, but you need to get a right radial A line sample in order to see what the patient's body perfusion is getting.
Excellent overview of this important topic. I serve on the ethics committee at my hospital, so any pearls about how we discuss this with the surrogate or the family? We have some institutions that do not intubate, limited resuscitation. Do you ever put time limits on ECMO as a modality for end of life? Just curious about how you handle that.
Yeah, it's obviously an excellent question, and especially these very sick patients and especially very prolonged ICU patients, it's a very delicate topic for family members. It's tough to see a family member in that situation. In terms of ECMO, when patients say they want no heroic therapies, this is definitely up there. This is invasive. It's a lot of things going on. It's expensive. There's no guarantee that, a lot of these trials say there's no difference from conventional therapy. So that's definitely a discussion that the hospital has to have with the surgeon or the ECMO team saying, hey, look, we think this patient is a good candidate for X, Y, Z reasons. We can foresee this patient being weaned off pretty quickly. Maybe he just needs it for they need it for the surgery. We're confident that after this intrathoracic procedure, what have you, those patients will be off. ARDS patients are very difficult. These patients are very sick for a while, especially now with a few years ago at the height of the COVID pandemic, ECMO research was booming because all these patients had ARDS and everyone was getting VV ECMO. So this is where a lot of the new data is coming from. And unfortunately, there is no, in terms of ethics, saying, look, hey, this patient's going to go on ECMO, they'll be okay. So it's definitely invasive. It's a lot of things going on, and it's a very tough decision for the family to make.
And we do have one question in the back. All right, so again, let's give a hand of applause to Dr. Gonzalez. Safe travels. Our next speaker is my wonderful colleague from Columbus. We work together at the Department of Anesthesiology at The Ohio State University. Dr. Chantel Gray joined the Department of Anesthesiology at The Ohio State University as an assistant professor in 2017. Clinically, her practice includes caring for patients in the operating room, as well as the care of the critically ill in the surgical and cardiovascular intensive care units. She currently serves as the Assistant Director of Faculty Development for the Division of Critical Care, as well as the Faculty Liaison for the Cardiothoracic and Vascular Surgery Advanced Practice Providers. Her lecture is entitled, My Patient Survived the ICU, Now What? Please join me in welcoming Dr. Gray.
Well, I'd like to thank Rafal, also an esteemed colleague, for that introduction. And I'd like to take the time to thank the AOCA actually for the invitation. So we are going to take a little bit of a hard left from the last presentation that we had, and I'm going to ask you to start to consider with me what actually happens to our ICU survivors. So I have no disclosures to report. And really, the guidelines for our talk today are going to be describing what's been defined as post-intensive care syndrome, reviewing some of the interventions that are aimed at preventing post-intensive care syndrome, which I'll frequently refer to as PICS for short. I wanted to discuss the development of post-ICU care clinics and then assess the effectiveness of follow-up services for post-ICU patients, and then take some time to consider some future interventions that might actually help to address the needs of ICU survivors. So improvements in ICU care over the past decades have really resulted in a huge increase in the number of patients who actually manage to survive their ICU stay. Just to give a little bit of context, every year there are about 14 million patients worldwide who survive sepsis hospitalizations. Here in the United States, we actually have about 4.8 million patients who are ICU survivors every year. As a result of this, which is fantastic, by the way, we have patients who are sicker, right, and who are getting improved care, and we are seeing the improved outcomes as a result. But there's a huge interest now in studying this particular patient population because a lot of long-term functional outcomes have been identified as a research priority, particularly in the critical care community, to just get a feel as to how our patients are doing actually after they're able to get out of the ICU. And that led to the development of a conceptual framework that we're referred to as post-intensive care syndrome, which is a constellation of symptoms actually that's been noted in patients who have survived critical illness. Let me see. So there are actually several different types of impairments that have been noted, and they've been grouped into just three overarching kind of areas. The first is physical deficits, the second is cognitive deficits, and the third is psychological. So when you're looking at physical indications or of PICS, one of the things that we notice is, there's a lot of weakness that's developed as a result of being in a bed for a long period of time in the ICU. So a lot of these patients will start to complain or have complaints of reduced strength, particularly in their larger limb muscles or even in hand grip. A lot of these patients, might leave the ICU with some sort of amputation, for example. So a lot of our ECMO patients actually do end up developing thrombus in various arteries, and that might require fasciotomies with wound vac placement. Or in the worst case scenarios, it might require an amputation of a limb. Dyspnea is a common problem. So even though patients might be liberated from mechanical ventilation, some of these patients might continue to still have shortness of breath. Dysphagia is a huge problem. So you might have patients who have required some sort of prolonged mechanical ventilation, and as a result might have had a tracheostomy placed. And then they're not able to utilize their tracheas, you're not utilizing that esophageal musculature to support eventually nutrition down the line. A lot of these patients have chronic pain and or they're at risk of developing a chronic pain syndrome. And then along with all of this is just impaired mobility. Cognitively, a lot of these patients will complain about problems relating to attention. They don't have as robust of a memory. There might be issues with language or executive functioning. Processing and motor speed can be affected, and then visual spatial abilities. So you can imagine if you have patients who were working, for example, prior to their critical illness, not being able to have focus or attention or memory or executive function can really cause significant morbidity down the line, especially if and when they get to a point where they would like to return to work. And then there are also a lot of psychological sequelae, and this is something that's been studied for a long period of time, but a lot of our patients end up having some degree of anxiety or depression. A lot of patients will go on to develop some sort of PTSD. And of course, if anybody has had any experience in the hospital setting outside of the ICU, you know that it's impossible for our patients to sleep. So when you're in the ICU and someone is constantly checking your vital signs, there's a lot of movement in and out of the room. Sleep disturbances are highly reported. So this next graphic, actually, I really like, and it is a little bit busy, so I apologize for that, but I think the busyness actually helps to illustrate the complexity of the patients and their psychological and physiological derangements that arise as a result of an acute care illness. So taking out of consideration anybody who might be coming into the ICU with any type of pre-existing conditions. We have a lot of sequelae that end up happening just as a part of the pathophysiology of acute illness within itself. So inflammation, hypoperfusion, muscle weakness can all lead to pathophysiologic symptomatology that is actively being treated in the ICU. But then on top of that, we have patients who aren't being fed as frequently, who aren't able to actually get up and mobilize and get out of bed. We have patients who are on a lot of medications. A lot of times, several medications are being added, and those medications might actually be things like sedatives or pain medications. We have the additional burden of sleep deprivation. And a lot of these patients are socially isolated. And I think that that's something that we really realized the importance of family and family engagement during the pandemic, when hospitals were closed to family members and we were trying to facilitate relationships via screens. When you look at all of those physical and physiological issues, then it's very easy to understand how we can get to a place where we are putting patients in a position where they might start to develop delirium, where they might become malnourished, where they are anxious and prone to develop, pain. And over time, what that means is that we have to be really cognizant of these patients after their ICU discharge, because they do, we now know, have cognitive impairment. They do develop psychological problems. They have ongoing weakness, and they might actually end up having new or worsening organ system failures. So over time, there's been a lot of work, particularly through the Society of Critical Care Medicine, to try to prevent what we now know as PICS. And probably any good intensivist really loves a great bundle. And so SCCM has bundled what they consider to be best practices. And they named it the ABCDEF bundle. Now, when it first came out, probably in around 2018 or so, it was only A, B, C, and D. And then in the past couple of years, we've added E and F. A actually stands for assessing, preventing, and managing pain. B stands for both spontaneous awakening trials and spontaneous breathing trials. And those should be happening every day as a way to assess for ability to be liberated from mechanical ventilation. C stands for choice of analgesia and sedation. One of the things that we've been finding is that our patients were probably not receiving enough pain medicine to actually control their pain. and they were being over sedated. D stands for delirium, so we tried to assess, prevent, and manage delirium. And in all of our multiple trials, non-pharmacological intervention is still the gold standard. Early mobility and exercise. This is something that is not necessarily an easy lift. Even in the time that I've been in OSU, we've made tremendous progress in being able to mobilize our patients. We now actually have a dedicated physical therapy team for the ICUs, but it literally takes them a 12 hours day of work if there are 12 patients in the ICU that need to be mobilized, because each patient, right, literally takes an hour. Then if we remember some of the photos that you saw of patients who were on ECMO, imagine trying to get those patients up and moving around, which is actually something that we should be doing. And then last but not least is family engagement and empowerment. So when you bundle all of these best practices together, there actually is pretty significant outcome. We are able to reduce delirium and code-blend days by 25 to 50%, which is significant given the fact that delirium itself is a predictor, an independent predictor for mortality. We're able to reduce discharges to nursing and rehab facilities by 40%. Also a big deal, right? Because that means that your patients are able to leave the hospital and go home directly, as opposed to having to go to a SNF or an LTAC. We're able to decrease ICU readmissions by half. So any person who is responsible for the financial health of a hospital institution is going to be happy about that. It reduces physical restraint use by more than 60%, which is also significant, knowing that physically restraining patients actually does contribute to delirium. And then decreasing the likelihood of hospital death within 7 days by 68%. So once our patients are actually able to get out of the ICU, they still have a lot of complex medical needs. And we're essentially discharging them into a space that requires a lot of coordination of care. So this graphic actually just shows some of the extra services that patients after ICU might actually require. So a lot of that is pharmacy services. So there are a lot of medications that might have been initiated or discontinued during an ICU stay or during a hospitalization. This is the opportunity also to kind of wrangle polypharmacy. Durable medical equipment. So again, patients might have lost limbs, right? Or they might not have the same mobility that they had prior to coming into the hospital. And so being able to provide wheelchairs or other mobility devices. Same with oxygen, right? A lot of our ARDS survivors still aren't necessarily back to baseline. They might not ever be back to baseline. Subspecialty medical care. So this is particularly important when you consider the high rates of acute kidney injury that actually might go on to require support of dialysis. So hooking those patients up with nephrologists so that they can receive ongoing dialysis treatments. Optimal rehabilitation therapy, so continuing your mobilization, continuing your exercise, occupational therapy services, nutritional services, right? A lot of these patients might have issues with nutrition after a critical illness. A lot of patients aren't interested even in eating, and they're not able to sustain their caloric intake. Speech language pathology, and another thing that falls under this umbrella would be screening for returning to work. Improving health habits, right? So if you have somebody who might have had a substance abuse issue or who is a smoker, providing those smoking cessation education and services or substance abuse treatment. The diagnosis and management of cognitive impairment, and this is one that is highly specialized, right? Because you might be getting into the need for a neuro assessment or some sort of neuropsychology. Speech language therapy, rehabilitation, and again, also screening for returning to work, because if patients are having issues with memory or attention or executive decision making, then they might not be able to return to employment. And then the diagnosis and management of any type of mental health problems. So again, our patients after critical illness are very highly prone to high anxiety states, depression, having to get used to this new normal, right, and what that actually looks like on a day-to-day basis. So basically, you know, we're at a place where we have complex patients with complex needs, and there's an ongoing discussion as to how we should actually move in order to get these needs addressed. And that is being undertaken by the creation of what we're calling post-ICU care clinics, or in other parts of the world, they might be called aftercare and recovery clinics. Typically, in our system at least, patients tend to follow up with their primary care physicians after an acute hospitalization, whether that be an ICU stay or not. I would actually argue that this is a perfect place for the anesthesiologist intensivist because we're really well poised, right, to kind of position ourselves within that perioperative management, that perioperative realm. However, as things stand, I think it's just really important for people to understand the concept of post-ICU care and post-ICU syndrome, so that instead of being siloed, we can actually start to think about this in the context of a conceptualized framework. To date, there have been several trials that have actually looked at aftercare and recovery clinics. One of the first that was actually published came out of a group who was located in the United Kingdom, and they looked at whether or not patients benefited from rehabilitation after critical illness. And they actually did demonstrate that there was some benefit to rehabilitation. What they did was they provided their study group with a rehabilitation manual, and they just asked them to go through the manual and follow the manual guidance. The same thing was done actually by a second group in the UK also, and this was called the Practical Study. This is a follow-up study that was completed in 2009, and they randomized two different patient groups. One was controlled, and the other was actually randomized to see a nurse-led clinic for follow-up. And what they found was that there is actually no increase in health-related quality of life when patients were seen in this nurse-led clinic, which was kind of interesting because you wouldn't necessarily think that to be the case given the first study that was published. Subsequently, then, we had the Recover randomized trial, which was published in JAMA of 2015, and it actually showed the same thing. Patients were highly satisfied with being seen after their ICU stays in some sort of clinic, but it actually didn't show that there was any significant difference in the outcomes that were measured, and those outcomes dealt with physical recovery after their ICU stay, as well as their quality of life. So finally, then, we were able to get enough data to justify a meta-analysis, and this was a meta-analysis that was published in 2018 in the Cochrane Review, and it actually included a total of 4 randomized controlled trials and then a single non-randomized trial. And this was of adult participants who were discharged from the hospital following an ICU stay. They were able to compile enough studies to actually have about 1,700 patients who were very heterogeneous in the reasons for why they ended up in the ICU. And they had a lot of different critical illness disease types as well as various severities. The main objective of this study really was to assess the effectiveness of follow-up services in relation to health-related quality of life, mortality, depression, anxiety, PTSD, physical function, cognitive function, and their ability to return to work. What was interesting, again, is that there was no evidence to show that post-ICU care clinics actually were effective in addressing any of these impairments across any of these domains of recovery. The secondary objective, actually, I thought was rather interesting, and that looked at the timing of the services that were being provided, whether or not the services were being provided by nurses versus physicians. They also looked at various countries, right, and whether or not there was some effect in the healthcare system delivery that might have affected the efficacy of these services. And again, none of that actually played out. The question then is, why are we pushing forward, right? If we have data that shows that these aftercare clinics are actually working, then why do we see, the pop-up of all of these clinics, not only in the United States, but also around the world? And I would argue that it's simply because of the fact that we don't have enough evidence as it stands to determine whether or not these aftercare services are actually valuable. So, as in medicine, if at first you don't succeed, then you just keep trying, right? And that's kind of the phase that we're in right now. So, despite the fact that there's not a lot of firm efficacy data, academic societies, again, mostly the Society of Critical Care Medicine, as well as several healthcare systems, have supported the creation of post-ICU care clinics. I put this link actually to the SCCM website because they've recently developed the Thrive Task Force. And this is an initiative actually that has gone on to create a consortium of learning collaboratives that will study basically the feasibility and effectiveness of ICU aftercare interventions. So the SCCM is actually funding what is going to be the largest qualitative study of ICU survivors, caregivers, and physicians to date. So it's something to look forward to as they're in the process of collecting this data. And I'd imagine that within the next couple of years, we should start to see some of those publications trickling out. So looking ahead, what are some of the things that we can potentially consider in providing services that actually are effective and meaningful to post-ICU survivors? One of the things to think about that I think is really interesting is the response, right, of various conditions. Not all patients, while critically ill, are equal, right? So there's definitely a continuum of those who are, yes, critically ill, but kind of less critically ill than those who are severely critically ill. Another is the concept of patient phenotypes and the concept of individualization. So this is something that's been studied and starting to be delineated in the ARDS literature, for example. So inflammation doesn't affect all bodies equally. And we're starting to realize that there are some phenotypes of ARDS that are way more severe and that result in a severity of critical illness that is not necessarily the same in somebody who might have, for example, just mild ARDS. Determination of management factors, defining PICS. So yes, we have a nice bundle that gives us some guidelines as to what we should be doing in order to help prevent PICS. But are there other things that we don't yet know or that we're not aware of, and ways in which we should change our management even in the ICU? predictive modeling. So, a lot of data points into an EMR from these very critically ill patients. Is there some way that we can mine this data and potentially use AI to give us predictive models as to who's going to respond to post-ICU care services and those who might not, based off of, again, the phenotypes that they might display during their illness. Specialized care timing and integration. So we don't really have a great understanding as to when these services should be started. Yes, we know that patients are having symptoms 3, 6, 9, maybe even 5 years post-hospitalization, but when do you start rehab? When do you start, language or cognitive retraining? What's the optimal time? Again, we still don't know. And something that's near and dear to my heart is the concept of ARAS protocolization. So enhanced recovery after surgery. We have a whole list of things or interventions that we can do in order to get patients back to their baseline as quickly as possible. Is it possible for us to also incorporate or develop an ARAS and enhanced recovery after ICU? So with that, I think I'm pretty close to my time. I would like to thank you all. Here are my references, and I will take any questions at the appropriate time.
Thank you, Dr. Gray. I would like you to join me here at the panel, and we'll take some questions at the very end. And our last speaker, definitely not least, is the specialist in broken hearts of any age, and he's coming to us from Nebraska. So Dr. Timothy Welch is a pediatric cardiac anesthesiologist/intensivist with a practice for caring for children with congenital heart disease throughout the entire perioperative continuum. He completed his anesthesiology residency, followed by fellowships in pediatric anesthesia and critical care at WashU in St. Louis. He currently serves as the program director for congenital cardiac anesthesia fellowship and director of the section of pediatric cardiac anesthesia at the University of Nebraska Medical Center. He will be speaking on the perioperative considerations for adult congenital heart patients for non-cardiac surgery. Please join me in welcoming Dr. Welch.
Thank you, Raf, for the nice introduction, and thank you to Dr. Geller and the AOCA for inviting me here today. I always really enjoy coming to the Don Cesar. This is one of my favorite hotels. I don't have any conflict of interest or financial disclosures to report. And we'll get right into it. This is an extremely broad topic to cover in a half hour, but I'll do my valiant best to do so. So we're going to start by talking about sorry, I got the clicker wrong. Some of our objectives today. So first thing will be to orient you to what the disease burden of adult congenital heart disease is in the United States currently. And what I'll hopefully show you is that although we think of this as a children's disease, the predominance of the disease burden lies in the world that you take care of, because most of these patients are now adults. We'll explore a little bit about the both cardiac and non-cardiac sequelae of congenital heart disease and its impact on how you'd manage them in the operating room. We'll talk about the predominant causes of morbidity and mortality, specifically heart failure, and then we'll finish up with some more practical anesthetic considerations for the perioperative management of these adults, kind of with, by specific scenarios. I think before we get into that, a show of hands, how many people here have taken care of adults with prior congenital heart disease in your practice? Okay, so fairly common, and this will be an increasingly more common thing as this cohort of patients ages. I think that probably it's worthwhile taking a brief detour, and I'm going to give everyone a very brief crash course in congenital heart surgery for two reasons. One is I think it's the most fascinating field in medicine. But more importantly, a lot of the language, the descriptions, the types of operations, I want to give you a common vocabulary so that these things are more familiar to you. I find it very inspirational. So, start out. This is a patent ductus arteriosus. This is a fetal remnant. Every patient has this in utero. It normally closes. And left patent in childhood, this will lead to progressive heart failure from left to right shunt. This guy on the left is Dr. Robert Gross. He was a pediatric surgeon at Children's Hospital Boston. He was the first person to surgically ligate a PDA, and this was his patient, Lorene Sweeney, at age 25 at her follow-up visit. No, this had never been done before. And so this was really the first congenital heart surgery. That's her at age 7 on post-op day 1, and that's her at Fenway Park at age 88. So she was the first adult congenital heart patient on record. This is tetralogy of Fallot. Tetralogy of Fallot is a lesion that consists of 4 primary problems. The primary issue is there's a large ventricular septal defect that sits right underneath the aorta, and the right ventricular outflow tract is hypertrophied and stenotic. So the consequence of that is progressive cyanosis. This is a group from Johns Hopkins Hospital, 1944, the first operation to try to address this surgically. And this was long before cardiopulmonary bypass, so what they did was create a surgical shunt to the pulmonary artery to provide pulmonary blood flow. If you haven't seen it, there's a tremendous movie about this called Something the Lord Made. It is outstanding, and it tells you this story. It's also a bit of a historical lesson. We used to call it the Blalock-Taussig shunt, named after Alfred Blalock, the surgeon, and Helen Taussig, the cardiologist. But the real hero of this story is a man named Vivian Thomas. Vivian Thomas was an African-American lab technician of Dr. Blalock's, and he basically invented this operation and got no credit for it until very recently. So we now call it the BTT shunt. And the other thing I want to point out is that this surgery was considered so high risk that the chair of anesthesia at Hopkins refused to anesthetize this child. And so his junior partner, Morel Hermel, said, I'll do it. So this is the first cardiac anesthesiologist in the country. This patient unfortunately died a few weeks later due to thrombosis of the shunt. This is an atrial septal defect, another common left to right shunt lesion that will progress to heart failure if not addressed. And the gentleman on the left is Dr. John Gibbons. So this was the first person to use the heart-lung machine to successfully complete an intracardiac repair. Obviously, if the heart is full and beating, you can't work inside it. So there's been a lot of work to design a way to do that extracorporeally. You heard Dr. Gonzalez speak about ECMO. This was where all this started back in the 50s. And this was the first real open heart surgery. This is transposition of the great arteries. So this is a reversal of the systemic and pulmonary outflows. They're connected to the wrong ventricle. And as you can imagine, if that's not dealt with, there'll be progressive cyanosis and shock and death in the neonatal period. The first attempts at repair tried to reroute atrial blood between the pulmonary and systemic returns by creating baffles inside the atria. And the first one to do that was a guy named Aoca Gs from Switzerland. So in 1959, he created the first atrial switch to try to restore physiologic AV and VA continuity. That was a technically demanding operation, as you might imagine. So a few years later, a Canadian colleague of his, Dr. William Mustard from Sick Kids in Toronto, developed a modification of that using prosthetic material or pericardial tissue. The problem with both of these atrial switch operations is as you can see, there's a very convoluted path that the blood takes through the atrium, and there's a high propensity to develop obstruction and leaks in those baffles. And those are patients that you may see. These are in their 50s and 60s now, and they're often having problems related to their atrial baffles as well as arrhythmias. So the modern technique for this is doing a switch at the great vessel level, not at the atrial level. This is another word on transposition. So some babies are born with transposition and have inadequate intercirculatory mixing because they don't have an ASD, they don't have a VSD, and they will be profoundly blue right out of the gate. And so that's the guy on the left there. He has a restricted septum. So there was a cardiologist named William Rashkind at Children's Hospital Philadelphia who said, you know what, a lot of babies have a small probe patent foramen ovale. What if I can get a balloon tip catheter across that, blow it up, and rip a hole in the atrial septum to let the blood mix? And that's what he did, and it bears his name. It's called a balloon or Rashkind atrial septostomy, and that's a schematic and a cartoon and then an echo showing the balloon, and then at the bottom showing the Doppler flow pattern through the atrial septum. And this procedure is life-saving as a way to temporize babies until they can undergo an operation if they need mixing. Tricuspid atresia. So complete atresia of the right-sided AV valve, leading, as you would expect, to underdevelopment of the right ventricle. These patients can't get any blood to their left side, and so they need something done as well. As soon as that VSD closes, the baby's going to die. So there was a surgeon by the name of Francis Fontan, this is in the late 60s now, who said, well, what if I just bypass the right heart? The right heart's not doing anything anyway. What if I connect all the venous return and let it flow passively to the lungs? And that's indeed what he did. So the area encircled in red is the classic atriopulmonary Fontan. So you can see that SVC blood diverts directly to the RPA, and right atrial appendage is connected to the RPA. The two figures on the right are more modern interpretations of that operation, but this is still done today. And this is the final in a step of 3 operations that univentricular heart patients undergo. The most severe of which is called the hypoplastic left heart syndrome. So this is a situation, kind of the inverse of what we just talked about. This is where every left-sided structure is rudimentary. There's no mitral valve, there's a tiny non-functional LV and diminutive aorta, and so they're going to die unless something is done. And this guy's name is Bill Norwood. He was another surgeon from Philadelphia. And he said, what if I apply the Fontan principle? What if I give them a cable pulmonary connection, make them a single ventricle heart? The problem is you can't connect passive blood flow to the lungs in a neonate because their pulmonary resistance is too high. So he needed an alternative strategy. So what he did, and this is really interesting, this ties everything together. He had to create an open atrial communication for complete mixing. So he did a septectomy. You already heard about that. That's what the guys did with the balloon. He needed to create a neo-aorta. So this tiny linguini-sized piece of aorta, he sewed it side to side to the patient's pulmonary artery to create a neo-aorta to perfuse the body. And then he put in a BTT shunt to perfuse the lungs. And those combination of procedures is called the Norwood operation. And his first patient was operated on at day 3 of life and left CHOP at day 18 and went home, survived. This is an almost, to me, unfathomable thing to think about, that in just a span of less than 40 years, we went from an era where cardiac surgery didn't exist to a time when a fragile, complex neonate like that could be operated on and leave the hospital. The challenge, though, is that those patients are still alive now, and they're adults, and they have long-standing sequelae of repaired heart disease, and that's what we're here to talk about today. So first, what I want to do is talk a little bit about the epidemiology of this. Who are these patients? Where are they? What are they getting sick from? And so in 2019, Liu and colleagues conducted a meta-analysis of over 260 papers looking at a total birth cohort of 130 million births. And what I want to draw your attention to, the figure on the left with the green line that's logarithmically going up, that's the percentage of patients or the proportion or prevalence of adult patients living with congenital heart disease. And you see that over this time span, they're on the rise. You might ask, well, why would that be? You'd think this would be a pretty stable incidence year over year. The reason is probably because our cardiologists have gotten so outstanding at prenatal diagnoses. So these patients, oftentimes the diagnosis is made before delivery, and that's accounting for this uptick in prevalence. What's even more interesting, though, if you look at the red line, that's the subcategory of patients with the more severe types of disease, the Fontans, the single ventricle patients, and you see that that is actually on the decline, probably for the same reason. This is speculative, but a lot of these patients with a prenatal diagnosis will elect to terminate their pregnancy. So the epidemiology of what lesions we're seeing will start shifting over time as more of these pregnancies are not brought to term. Ariane Morelli is a Canadian. She's from McGill, and this is a kind of nice paper she did that tries to model the concept of a birth cohort. So the figure in the middle is really interesting. The blue, yellow, and red lines represent the prevalence of disease in different decades. And what you can imagine is over time, as medical and surgical care improves and babies survive longer, the surviving cohort of prevalence will start increasing and become additive. The figure on the right kind of shows you blue as children, red as adults, and over time, the proportion of adults with heart disease is now surpassing that of children with congenital heart disease. And that's another one that kind of shows that over time. This is Canadian data, but the same thing applies in really every developed country, including ours. So where is ACHD care provided? This is a controversial topic. There's proponents that are strongly supportive of both sides. I'll just say this. The advantage of a children's hospital is that we have expertise in the care of congenital diseases, but we are ill-equipped to care for adult comorbidities. And that's the challenge we face. On the flip side, an adult hospital is very comfortable with MIs and strokes and PEs, but most of them don't really understand these diseases very well. What is known is that patients have the best outcome when they're cared for in a dedicated ACHD center. Those are highlighted in red, and as you can see, there are large swaths of the country that are not proximal to any of those, and even fewer of the ones that are accredited. So the literature supports better outcomes in one of those places. The problem is there's just simply not enough of them. And so I'm going to show you an interesting slide next. Give me one moment. The centers that seem to be the most successful are the ones that try to bridge that gap by creating what they call a transitional care program that tries to take children that are kind of graduating from pediatric care and getting them linked in with adult programs that know about their disease. So this was an interesting paper that came out of Texas Children's a few years ago. What they did was look at the location of all the ACHD centers in the country and then geocoded them, measuring the average drive time for patients within their catchment area. And the darker blue represents higher population density areas. You can see they cluster in major metro areas, usually with a university medical center. And then you can see all the yellow dots represent the ACHD programs. You can see a large amount of the country is not near one of those, and 5% of the population lives more than 6 hours away from one of these places. The other thing that's interesting, that's the drive time radius. So you see the lighter blue, that's the farther away you are. And then there's also a significant socioeconomic and demographic barrier to this too. You see large areas in the Southwest and Texas that are highly populated, but also highly uninsured, highly Hispanic, and high rates of poverty. And those areas are often more than 6 hours away from these places. So what does this mean? It means that if you work in a non-academic, non-ACHD facility, especially in a less populous or more underserved part of the country, you will increasingly encounter ACHD patients in your practice. Sequelae of CHD. So this is a busy slide. It's kind of intentional. The idea is to show you that congenital heart disease touches every organ system. In an adult congenital heart disease, that's even more pronounced because you're not only dealing with the typical acquired diseases that adults get, but all the ones that are consequential to their previous heart disease. We'll go into some in a little bit of detail. So the gentleman at the top, everyone recognizes, has trisomy 21. These patients have significant airway problems that you encounter: macroglossia, atlantoaxial instability, laryngomalacia. The guy at the bottom has the 22q11 syndrome, DeGeorge, and they have micronathia. So you can imagine some of the airway challenges that those guys might present to you. As we mentioned, a lot of these patients require multiple serial operations to get them fully repaired or palliated. And in children, that often means weeks and months in the ICU, like Dr. Gray was talking about in her adult population. We deal with the same. I have had patients that have been in my ICU for most of their life. Consequential to being on the ventilator that long is an acquired subglottic stenosis. And in children, they'll often be a little bit hoarse and dyspneic. That can progress into young adulthood. They may present to you for procedures related to that, endoscopic dilation of the trachea, or even a complex laryngotracheal reconstruction. Any baby who's had work done on their aortic arch, like the hypoplastic left heart patient, are going to have their recurrent laryngeal nerve at risk. It's right in the operative location, and that will often cause a unilateral vocal cord paresis or palsy. Those patients are at risk for aspiration, dysphonia, speech problems down the road. And then the final airway-related thing I want to highlight, a lot of patients with congenital heart disease will have significant enlargement of different cardiovascular structures, vascular rings, vessels that are in the wrong place, and that will often cause problems during embryologic development of the tracheobronchial tree. They'll become weak and unsupported, and they'll develop tracheobronchomalacia. They may present to you for procedures for that, like aortopexy, bronchial stenting, or sometimes even tracheostomy. These patients are at a significant risk of pulmonary disease. Some of it is related to repeated sternotomies and thoracotomies, kind of altering chest wall geometry. We do know from large series, when these patients are studied with PFTs, there's about a 50% incidence of severe, mixed, or restrictive lung disease, the severity of which, by the Kaplan-Meier, correlates with mortality. Pulmonary hypertension is a big part of this world. That's defined invasively in adults as a mean PA pressure at cath of greater than 25. We classically divide those into two categories, pre and post-capillary, meaning whether the predominant problem is left-sided heart disease or something else. In our case, it's mostly something else. It's presence of a large, unrestricted, long-standing left-to-right shunt. And that will eventually cause what you know as the Eisenmenger syndrome. So you might ask, well, then why not close those shunts so that doesn't happen? And that's indeed what happens. These patients may come to your hospital in their early 30s for a cath to sort this out, and the decision about whether they can safely get their septal defects closed really hinges on what their PVR is at the time. If it's greater than 8, they're not a candidate, they'll have RV failure. If it's less than 4, they're probably an okay candidate. It's the ones in the middle that often need to be challenged with pulmonary vasodilator drugs to see if they're responsive. And those drugs are targeted at 3 general pathways. You may have heard of some of these drugs before. The endothelin pathway, or drugs like bosentan, the nitric oxide pathway, or the phosphodiesterase inhibitors like sildenafil, and finally the prostacyclin pathway with drugs like epoprostenol. These drugs need to be continued through the perioperative period because rebound from these can be disastrous. And what we're really trying to avoid is what we call a pH spell or a pH crisis. So there are a lot of instances during perioperative care that can lead to an abrupt increase in PVR. All the things that you know about: acidosis, pain, agitation, hypoxia. When the problem is with these patients already have an elevated PVR, when it abruptly increases, the RV will start to fail, the septum shifts, the LV doesn't fill, cardiac output falls, coronary perfusion falls, and a bradycardic arrest is right around the corner. Other organ systems. So a lot of these patients are chronically cyanotic, and as you know, chronic cyanosis is a potent stimulus for erythrocytosis. So they're often polycythemic and hyperviscous, putting them at risk of deep vein thrombosis. However, cyanosis also leads to deficiencies in vitamin K clotting factors, fibrinogen, and and platelets. So they're both in this tenuous balance where they're at risk of both thrombophilia and coagulopathy. Chronic kidney disease is present, and acute postoperative kidney injury can be superimposed on that. The risks are age, coexisting LV dysfunction, use of chronic diuretics, use of ACE inhibitors, all of which are common in these patients. Liver disease is almost ubiquitous in Fontans. In fact, the final common pathway for a Fontan is a combined heart-liver transplant. And usually the reason for liver disease in these patients relates to congestive hepatopathy. So you can imagine if you're a single ventricle patient, the only way blood's getting to your lungs or getting to your heart is through the lungs. You need high venous pressure in your cava to drive that blood passively through the lungs into the single ventricle. That means their vena caval pressure is high. They have lymphatic hypertension and venous hypertension. The liver eventually becomes congested, cirrhotic, and fibrotic. The other mechanism for it would be in left-sided obstructive lesions, where the mechanism is more ischemia. And then finally, the CNS is also very much affected by heart disease. These patients have earlier onset dementia, have a higher likelihood of epilepsy, stroke, and dementia. So why do they die and how? So this is a paper looking at a cohort of 7,000 adults with CHD in the UK and comparing their survival to age and sex-matched controls in the general population. They followed them for 9 years. And overall, the main finding is that they have a higher all-cause mortality than a random person off the street. Table 2 at the top shows you the most likely cause for it is heart failure. 42% of the mortality is due to heart failure. This down here shows the proportion of heart failure as the cause of death, which increases with age. The most interesting thing to me is this center one here. So this looks at each different lesion: VSD, ASD, coarc, TET repair, all the way up to Fontan. And what it does is it looks at a representative 40-year-old with that lesion and says, what is their mortality risk? And that a 40-year-old with a Fontan has the same mortality risk as a 75-year-old in the general population, 20% 5-year mortality. This also looks at standardized mortality by lesion again, and you see the high-risk categories: Fontan, Eisenmenger. Just keep remembering those two words. Those are the ones you want to think about. So as we've discussed, the ACHD population is increasing, and in parallel, the proportion of ACHD hospital admissions that are attributable to a non-cardiac surgery is also on the rise. As you'd expect, the denominator goes up, so does the numerator. They still need hip replacements, they still need cholecystectomies, they still need eye surgery. And so this was a paper that came out of the National Inpatient Sample Database. Maxwell and colleagues looked at a sample of 100,000 ACHD patients compared to 37,000 matched controls, and they showed both a higher inpatient mortality and a higher composite morbidity score amongst the ACHD patients. Longer length of stay, higher cost, higher odds of having AKI, MI, stroke, death, and cardiac arrest. What about the pregnant patient? So these patients still get pregnant. There's not really a problem with fertility, but there is a problem with labor and delivery. So to support fetal gestation in any woman, the cardiac output increases throughout pregnancy during all trimesters, predominantly through an increase in stroke volume. The problem is if you've got a congenital heart lesion that's led to a pressure-loaded, poorly compliant ventricle, the abrupt increase in preload that happens during uterine contraction and uterine involution can precipitate acute heart failure. There are two classification schemes that are used to try to risk stratify parturients with ACHD to identify if they're in the appropriate center to deliver. One is called the modified WHO, the other is the CARPREG-2. And what they essentially do is look at these high-risk predictors to give them a numerical score. That score correlates with what their likelihood of an adverse cardiac event during L&D is. And again, the same themes come out: advanced age, Fontan circulation, AV valve disease, or decompensated heart failure, low ejection fraction, New York class 3 and 4. those are the ones that score high that needs to be considered maybe not to be delivering in a smaller, lesser resourced hospital. These are the ones that want to come to a referral center. Many of these patients will be on anticoagulation because they'll have prosthetic valves, conduits, grafts, and we prefer low molecular weight heparin in this population because of the teratogenicity of warfarin. That will have implications, obviously, on your ability to do labor epidurals and neuraxial anesthetics. To the extent possible, recommendation is that all elective procedures are deferred until after pregnancy, or at least until the conclusion of the second trimester. And fetal monitoring in the presence of both obstetric and cardiac anesthesia specialists is really helpful. The babies born to these women are at risk of both prematurity and IUGR for a variety of mechanisms. And the decision about where to deliver them should really be based on one of those scoring systems. The high-risk women should really come to these quaternary centers. So we're going to conclude with some more practical kind of anesthetic implications for what we're going to do to take care of patients when they come in for non-cardiac surgery. If you look in textbooks or review articles for this, a lot of times they try to be very prescriptive in cookbook, like do this if you have a TET, do this if you had a Fontan. I think that's kind of contrived, and I think it's a bit cumbersome unless you're a specialist. So I think what's really more relevant is to focus on what is the residual physiology that repaired lesion leaves them with now at this age. And if you think about it that way, it actually becomes easier because you're going to care for them the same way you do for anybody. The goal of intraoperative care is to augment and maintain good systemic oxygen delivery, and in the presence of patients that still have shunts, keep systemic and pulmonary blood flow balanced. It's the same thing you would do for anyone, it's just the margin of error is a bit smaller in this population. So some basic principles for all comers. You're at your hospital, you see an ACHD patient on your list, what do? I think the first thing is to ask, is it appropriate to do this case in my hospital? It may very well be. If this is a kid who had a TET repair and now they've got a normal RV function on their last echo, no pulmonary regurg, it can probably be done anywhere. If it's a Fontan who's showing early signs of heart failure, maybe not. So is there a regional ACHD center that your hospital is networked with that you can communicate with? Maybe this is a telehealth consultation, or maybe if it's elective surgery, you just get them transferred. I think first case starts are preferable. As mentioned, a lot of these patients are dependent on adequate preload, especially before induction. And so, this is not a case to do at the end of the day. Meds is another thing to talk about. So many of the patients, just like we talked about for a pregnant woman, are going to be on all sorts of different anticoagulants and antiplatelet, antithrombotic agents. The difference here is that many of these patients are absolutely dependent on patency of these shunts for survival, and thrombosis in situ can be catastrophic. So when in doubt, this is probably a patient that maybe admit the night before, keep them hydrated, bridge them with heparin until surgery, and then get them back on their meds. Most of the other cardiac medications, with the exception of ACEs and ARBs, which you generally want to hold to prevent them from being vasoplegic, want to be continued without interruption. Antiarrhythmics, digoxin, beta blockade, and specifically pulmonary vasodilators need to be continued throughout the perioperative period. A bit on the kind of the setup. So, for many patients, especially if you're doing any kind of thoracic procedure, they've had multiple operations in the chest. So anticipate, possible sudden blood loss, large bore venous lines, and those lines need to be meticulously de-aired in the presence of open right to left communications. Invasive monitoring is probably indicated for all but the simplest ACHD cases with a few caveats. So a patient that underwent a classic BT shunt where their innominate is sewn to their PA are going to have diminished perfusion on that side. So arterial access is generally contralateral to that. The other opportunity for that would be a patient who had a coarctation repair. That was classically done by taking a flap off the subclavian, again, rendering that arm a little ischemic. PA catheters are very unlikely to be used in congenital heart surgery. That may differ when they become adults, but we certainly don't use them at all in a children's hospital. Central venous catheters are common, but you have to think about what their anatomy is. So if you have a Fontan, a catheter in the right internal jugular is not transducing a CVP. It's actually a PA pressure. That may still be very valid and useful information for you. Just know where it goes. And the transposition patients who were operated on prior to 1980 probably have an atrial switch, and who knows where that catheter is going. And then finally, the last word on TEE. A lot of folks are certified in basic perioperative TEE. Unfortunately, the focus of that course is really on structural adult heart disease, and really to interpret a lot of these images, you really need some expertise in congenital imaging. All right, so we'll finish up with just kind of a few of the basic categories. I don't think you should see left to right shunt lesions, because by the time you're an adult, you've either had it repaired already because you were in heart failure as a child, Or if you didn't, you no longer have a left to right shunt, and you have Eisenmechers at that point. So we'll talk about it a little bit for completion. The primary problem with left to right shunts is you overcirculate. There's too much blood flow to the lungs, and over time, as we talked about, that'll lead to pulmonary vascular remodeling and eventually pulmonary hypertension. These patients will chronically be on diuretics and ACE inhibitors with all that entails. They'll usually have a volume-loaded right side, so they'll have right atrial and right ventricular dilatation and some risk of arrhythmia from that. But what more likely is going to be the case if you see a 40-year-old or a 50-year-old with an ASD that never got fixed is they have a right to left shunt now because of the reasons we talked about. Another example, you probably won't see this in the US, but an unrepaired tetralogy of Fallot patient, perhaps maybe on a medical mission trip or an immigrant, they've had a long-standing right to left shunt. Their RV's probably starting to struggle, and they still have the ability to shunt right to left. They're going to be blue. They're going to be cyanotic. Your goal is to do anything you can not to let the PVR get any higher. Blood pressure generally maintained with drugs to keep SVR up and avoid things that make pulmonary resistance higher. The other thing to know is these patients are going to be slower to wake up because they have less pulmonary blood flow. So the offset time of inhalational anesthetics will be impacted by that. The Fontan or the cavopulmonary connection. So the hallmark feature of this lesion is the absence of a subpulmonic pump. So their blood flow, as we talked about, is passive. It requires high venous pressure, low PVR, and a compliant atrium. If any of those three things don't happen, it doesn't work. And so they need to come in adequately preloaded. They need their PVR well controlled. And anything that's affecting compliance in the common atrium, diastolic dysfunction, AV valve insufficiency, that will render the Fontan circuit not to work very well. So they need to be kept with good AV concordance, preferably sinus rhythm or a paced AV rhythm. The other thing to know is that anything that's going to impede venous return is going to compromise flow through the Fontan. So making sure they come in well hydrated while on the ventilator, keeping peak airway pressures low, and honestly preferring spontaneous ventilation if possible. That's going to improve cardiopulmonary interactions with this. Get them extubated as soon as possible. Pulmonary hypertension we spoke about earlier. We'll reiterate a couple points. Avoid it. Just avoid the pH crisis, and prevention is better than management for this. Have nitric oxide available, and I think the two vasoactives to keep in mind here are milrinone for its RV lusotropic effect and vasopressin as a systemic vasoconstrictor. Left-sided obstructive lesions, the perioperative management of this should be familiar to anyone here who takes care of adults with acquired valve disease. The primary problem is you've got a pressure-loaded heart, and that heart is happiest when it's full, slow, and when the resistance is tight. So a poorly compliant ventricle requires higher filling pressures to maintain stroke volume and needs a longer diastolic filling time to fill and maintain. So it will be intolerant of low diastolic blood pressure, propensity to ischemia, especially with acquired coronary lesions later in life. Regurgitant lesions are also common in ACHD. I listed a few of the situations in the CHD world where that can happen. The primary problem here is chronic ventricular volume overload, leading to progressive systolic dysfunction. So the goal here is to keep the heart fast and dilated. Why fast? The faster it is, less time in diastole, less regurgitation fraction, better forward stroke volume. If they've got a pacemaker, maybe turn it up a little bit and avoid vagatonic drugs. So in summary, the ACHD patient population, they're large, it's growing, they're geographically isolated. They will come to you with a wide array of both repaired and palliated lesions. Focus on the residual physiology. The mortality burden is high. It's much higher than the regular population. It's additive to whatever else is wrong with them, and it's primarily due to early onset heart failure. And finally, when you're screening these patients, look for the red flags. To me, the red flags are Eisenmechers, being cyanotic, having Fontan physiology, and having signs of early heart failure. So if you see a patient with a sternotomy scar, ask them why that is, right? Maybe they had a CABG a few years ago, or maybe they had a Fontan and they haven't seen a doctor in 20 years. Those are the ones you want to watch out for. So a few of my colleagues I want to recognize. I spent a bit of time at Texas Children's where we were fortunate to be big enough to have a dedicated in-house ACHD program within our children's hospital. Pablo Mota was our cardiac anesthesia director for ACHD. Cam Desfoulian ran a kind of an adult cardiac congenital ICU. He's a med peds guy. Ed Hickey was one of our congenital surgeons who specialized in ACHD care. And then now I'm in Nebraska with Dr. Geller. Nick Markin is one of our adult cardiothoracic anesthesiologists at University of Nebraska, specializes in this. And John Kramer is a med peds cardiologist who runs our program, They're all great guys and good friends. I tried to put my references on a QR code. My 9-year-old told me he would show me how to do it. I was like, there's no way to do it, so I just did it the old school way. So if you want to look up, these are some fantastic papers that'll give you a good overview. Thank you.
Thank you for both wonderful presentations. We really enjoyed it. And now we're going to open it up for questions from the audience. And maybe I'll start with Dr. Gray. So let's say you're a generalist and you're pre-oping a patient, and you find out that the patient was just hospitalized for a prolonged ICU stay, maybe sepsis, let's say, in the ICU for 3 weeks, and then they went to the rehab, and now they're coming in 2 months later for some non-related surgery. What would be some questions that you would ask that particular patient?
That's a really good question, actually. I think that when it comes, I think it actually depends on the type of procedure that they're coming in for. So if this is something that's completely elective and, it's it's not an acute gallbladder, they, are coming in for a cholecystectomy, then the questions that I would ask would be slightly different than if the procedure was something that I expected there to be a longer hospitalization and or even an ICU stay. So for somebody who is coming into an patient surgery center and they're expected to go home, one of the things that I would really be curious about is their pain management, right? So you could expect that these patients might be coming in with some residual pain syndrome or pain sequela, and that's something that you would certainly want to address in the perioperative period. Another would be, their nutritional status, whether or not they're able to eat without any difficulty at home. I would definitely want to make sure, that they're able to that their digestive system is working, right, and that they're not going to become some sort of aspiration risk. I would be concerned about their airway, right? So if this is a patient who had a prolonged mechanical ventilation and, might have had a tracheostomy, for example, some patients are able to be decannulated and then frequently come back for additional surgical procedures, but you would certainly want to know what those residual airway concerns might actually be. If I anticipated that the patient would be staying for a long time, then I would definitely be curious about their psychological history. So I would want to know about any history of anxiety or depression. I would want to know any signs of PTSD, because obviously that can come into play as the patient is emerging from anesthesia, but there also might be some other medications or anxiolytics that you can utilize, and you can also be kind to your ICU colleagues and kind of give them a heads up.
Very good. Now, Dr. Welsh, I do have a question about polycythemia that is experienced by the adult congenital heart patients. I did, in my training, see one patient before I knew anything about anesthesiology who came in with a hemoglobin of 23. And I was wondering, what is the most current recommendation of approach to that amount of hemoglobin, as at the time it was a phlebotomy? Is that still something that we do?
Yeah, a lot of it depends on the age of the kid. In congenital heart surgery, we're typically using bypass circuits that are pretty small, but often they need a blood prime to maintain adequate crit. A kid like that would obviously get a clear crystalloid prime. Sometimes phlebotomy to lower it a little bit. There's some pharmaceuticals that are sometimes used as well, and sometimes just isovolemic hemodilution, so just withdrawing off blood prior to and then having that as fresh whole blood to give after bypass. Those would be some of the strategies. I had an unrepaired teenager we saw a few months ago who came in with a hematocrit of 70. It was pretty amazing. And you can imagine, someone like that, their blood is like sludge, so they're at very high risk of thrombosis.
How did you approach that one?
The things we just talked about.
My first question's for Dr. Gray. I've specialized personally in pediatric pain, and as we intersect with the ICU with patients that either go straight there after surgery, like a neuromuscular spine, or have patients that have had prolonged ICU stays come through the OR, I think it's become a better conversation now, but not quite adequately addressed for people taking into account the fact that their receptors aren't the same as someone who would be never exposed to opioids. And there even have been studies that those that were naive but exposed to drips for a short period of time take a significant amount of time to return to baseline. And one of the ways that we try to have a good collaborative conversation is to try to ensure that the pain considerations are of equal measure to the hemodynamic considerations that take front and center stage when they're in the ICU, and the fact that when one is undertreated, it actually is negatively or positively contributing to the other. What do you think has been the most successful way to collaborate with the ICU when you're having a post-operative patient so that they don't discount one or discontinue everything in order to treat the other, to ensure that pain is adequately treated, knowing that there is chronic long-term sequelae that can result from inadequate pain treatment?
Sure. I think that, to your point, you simply have to have the conversation. Thankfully, in our ICUs, we actually work in a fairly highly collaborative environment, and so it's not difficult or unheard of to have a conversation from the OR, attending anesthesiologist directly with the intensivist. I think it helps as well because in our practice group, we're all anesthesiologists, and so there's a lot of consideration. I think I'm personally aware of if I'm caring for a patient in the operating room, for example, that I know is going to end up with one of my colleagues in the ICU. I also would like to hope that ICU providers and intensivists are more aware of the A, B, C, D, E, F, which sure is going to turn into, the rest of the alphabet by the end of my career, that people are aware of the importance of pain management, assessing for pain, treating that pain, right, while also keeping patients comfortable if they are needing some sort of sedative medication. A lot of that education happens from us as intensivists to our nursing staff, particularly in the context of sedation, because propofol, as we all know, is a sedative hypnotic, but it does absolutely nothing to treat pain. So when you have patients, for example, who might come out in our cardiovascular ICU that we're trying to get extubated, they lift their sedation and nursing gets, upset because they're not able to calm the patient down. They're not following any types of commands. But the first question that I always ask is, did you treat the patient's pain? Because clearly if you've had a sternotomy and you're lifting somebody's sedation, they're not going to follow your commands because you haven't addressed, the fact that they're having severe pain. I would also hope that the multimodal approach, is one that's not only initiated pre-operatively, but one that we can take post-operatively. So we've been a little bit more aggressive, I think, in our ICU over the last few months in particular with incorporating regional anesthetics and or the placement of catheters post-operatively in some of our patient population to help with that very thing.
I have one more question for Dr. Welch. Given the paucity of access in the greatest need areas sometimes of a a person who is well versed in what to do for a certain type of adult congenital heart patient, is there an avenue that is already known to be able to reach out if you can't transfer that patient to somebody you can have a discussion with and they can give you some input in order to be able to successfully get that patient through?
Yes. Okay. I think the first line of attack is to find out if you have anybody institutionally where you're at that can help you. So even in a non-accredited ACHD program, there will frequently be some cardiologist on staff who kind of has a niche interest in this stuff. That's your first go-to person. If you're not getting the answers you need from that, there's a website, the ACHD Association, ACHDA. They have a website that shows where all these programs are geographically. There's probably one closest to where you are. If you're part of some hospital network, that hospital network may already have an established relationship with one of those centers. That'd be the one to go to. And I think as the pandemic taught us, a lot of healthcare now can be handled via telemedicine. So it may not be that this patient needs some specialized service or provider that's only at the big place. It may just be you consult with one of their people over the phone, make sure you've done all the right things. They can advise on any additional testing that might be needed. If the operation is elective, maybe it could be rescheduled and the patient could be transferred, assuming that's feasible. So I think it's a layered offense depending on the acuity of the case and what resources you have locally.
Any other questions from the audience? Alrighty, thank you very much for the presentations. We are really grateful. And for the audience, please rate the presentations on the app. And then we also invite you to join us at the presidential reception at 5:30.